try passcode 025993.
025993. Okay.
It's okay, we've still got late stragglers going in.
We'll give that a minute. Oh, and I've accidentally joined on my phone. I don't want to do that.
All good?
I suppose get going. I'll keep an eye on the situation if that's okay.
Okie dokie. All right then. So, yep. Welcome one and all to, it's February, I think. Gosh, our time is flying by in 2021 already. This evening, we are joined by Victoria Simpson from Liverpool. Victoria is a final year medical student at the University of Liverpool who's already come out of a master's from the Liverpool School of Tropical Hygiene and Medicine. What an incredible achievement that is.
Thank you very much.
So, yeah, indeed. Alongside all of the clinical stuff going on in Vicky's life at the moment, Vicky's got very much of a deep interest in antibiotic resistance, how it's changing around the world, and has been working for last year with a research team based in Malawi, looking at the kind of social relationship between the people there and antibiotics resistance that's becoming a big challenge around the world. That's what we're going to hear about this evening, and it's sure to be an interesting one with some scary stories and hopefully some optimistic news as well. So thank you so much for joining us, Vicky, and it's over to you now for the next hour. We'll be taking Q&A at the end, so feel free to drop your questions in the chat throughout. Thanks so much for joining.
Okay, thanks very much, Ben. Bear with me a moment. I'm just going to get my share up. And if someone can let me know if this has worked. I've got my camera back on as well. And there we go. All visible? Okay, so yeah, as Ben's just said, my name's Victoria Simpson. I'm a final year medical student at the University of Liverpool. So that means I'm 6 years into a medical degree now. I've got about 6 months left to go and then I'm a doctor. And in that time, I've seen a lot of antimicrobial and antibiotic use within our own healthcare system. And as Ben's also said, I was doing a master's last year where the research that I got involved with was relating around this. So it's something that I'm very interested in. It's something that I think that we don't really have enough of an understanding of in society. So I'm going to hopefully convince yourselves and anybody watching on YouTube today that antimicrobial resistance is something that we need to kind of listen out for. And I'm going to give you a bit of information about it in some ways that perhaps we can all be a bit more proactive in our futures and help curb the problem a little bit here. So I've titled it Antimicrobial Resistance, the Antimicrobial Armageddon, how we got here and what we do next. So I'm going to be talking, as I said, about antimicrobial resistance, what it is, how it happens, what our global status on it is, what we did to get to this point where we are now, and what are some of the things that we can do to halt, if not reverse it, a little bit. So something a bit more positive at the end, hopefully, for you. So what is it? I think it's always best to start with some definitions. So whether you're tuning into this as a fully fledged microbiologist or doctor, or you're somebody that has absolutely no knowledge of it, doesn't matter. As with everything in healthcare, there's a lot of misconceptions, and it's always best to start by debunking them. So antimicrobial resistance is a state that's acquired by microorganisms, which you might know better as microbes or pathogens. These little mechanisms they get that help them evade the medications that we use against them. And an antimicrobial is a collective term for a group of drugs that we use against microorganisms. So this includes antibiotics that we'll all hopefully be very familiar with, which we use against bacteria. Antivirals, which aren't quite as common because we don't have as many of them, that we can use against certain viruses. Antifungals that you might be common with if you've ever had, say, athlete's foot or anything like that, that we use against fungal infections, and so on and so forth. Now, antibiotics are certainly the most well-known of these. If you've not been on them at some point in your life yourself, you'll definitely know somebody who has. They're very central to our healthcare system and the way we think about medicine. So if I use the term antibiotic resistance, sometimes it's used interchangeably with antimicrobial resistance. They are slightly different just because antimicrobial resistance talks about all these other types of drugs as well, but we tend to focus on antibiotic resistance just because antibiotic use is so widespread in our societies. But we are concerned about resistance across all these different types of drugs just because of how much we've come to use them and rely upon them over the years. So I put this very nice little picture up here for you, just to get you familiar, if you weren't already, with what I mean when I talk about microorganisms, also known as microbes or pathogens. So the pictures here, some of them you might be familiar with, some of them you might not be. And these are the different broad categories of microorganism that we have. So if you can see my cursor here, you might be quite familiar with bacteria. We've already talked about viruses and fungi. You might not be as familiar with parasites and prions and so on and so forth, but these are just some of the different subtypes. They live in the world around us. They're microscopic. We can't see them, but they're obviously known to cause various different types of infectious diseases that are of concern. So for instance, in the virus category, we've got HIV, coronaviruses. In the bacteria category, we've got Staphylococcus aureus, E. coli. In fungi, we've got all the different kind of types of tinea that cause different infections in different parts of the body. Some of these infections are more worrying than others, but doesn't mean that we don't care about them all. And some of them even, we tend to associate them with diseases, but bacteria, they live inside us anyway. So they're actually hundreds, if not thousands of them on your skin, in your respiratory tract, in your gut. And we need them to maintain kind of nice functional internal conditions, if you will. So the bacteria that are in our gut, for instance, are very, very responsible for how a lot of our digestive processes are. And if those conditions aren't maintained, a bit like herds of animals, if one's killed off a bit too much, another might be allowed to get a lot bigger. And that's when we can start to have problems. And within these different subtypes I've broken down of bacteria, viruses, I've already mentioned that there are different subtypes. And then further within those subtypes, you get a lot of different strains. So in the same way that as human beings, lots of populations, depending on where we are in the world, we can all look and have different types of DNA and behave quite differently, for example. It's the same, for instance, with different types of bacteria. So you've got unique strains. So within one type of, say, Staphylococcus aureus, there will be different strains of that all have slightly different genetic mutations that make them a bit different from one another. A working example of this that we've seen is with the coronavirus at the moment. We've had all these breakout mutations and different strains, but they're still coronaviruses. So that's kind of what I'm talking about there when I'm getting at different strains. And the same thing is seen with antimicrobial or antibiotic resistance, where you will get resistant strains and non-resistant strains that would respond or not respond to different types of antibiotic if you try to treat them against it. So although it's quite interesting from a genetic point of view, this resistance is particularly concerning for us because we spent years trying to develop these drugs since they were accidentally discovered by Alexander Fleming almost a century ago. We spent a lot of time and money trying to develop these drugs that help us prevent these infections or cure these infections that are really life-threatening. And we've used them so much to the point that now they're not as useful as they used to be. And this is scary because the mortality and morbidity, which is the deaths and the kind of long-term effects for people who do survive of these illnesses, is back on the rise again. So the super drugs that we've developed against these different types of organism are falling prey to so-called superbugs. So how does it happen? I've tried to simplify this process quite a bit because it's something that people have entire doctorates spent studying, and it's most easily understood in the context of bacteria and antibiotics again. So I'm going to try and talk us a little bit through that. So resistance might sound a little bit as though we're talking about microbes having built up some kind of an army, having an uprising. It's a lot simpler than that, really. It's simply that it's an evolutionary process, the same way that any kind of genetic trait arises in an animal or in people, for instance, that then becomes the dominant trait that helps them survive better. So a random bacteria could have a completely chance mutation, and that mutation could give it some kind of property that means it's able to evade antibiotic. So then when that antibiotic is used, as you can kind of see in picture 2 here, it's going to kill off all of the susceptible bacteria, but the resistant strain will remain. It will go on to multiply and become the dominant strain. And it's even got mechanisms whereby it can share that bit of DNA that gave it that advantage to survive onto other nearby bacteria, sometimes of different species even. And then that resistance is shared out because it's an advantageous trait. So whenever we use antibiotics, we're increasing the likelihood that these chance mutations will be the ones that win out and become more dominant. So they've now become more adapted to their environment. They'll replicate further, and this further replication means that they can spread to other tissues more easily. They can cause deeper-seated infections, so more likely to go on to cause, say, sepsis and end organ failure, because they're harder to treat in the first place, and then jump to other hosts when the opportunity arises. And with bacteria, this tends to be through what we call fecal-oral spread. So when it enters through our gut and it gets into the environment that way and contaminates things, or obviously if it's in the respiratory tract, when we cough, when we sneeze, things like that. So as I said before, this is a very simplified version of what happens. Lots of people do research into this, but there are lots of different mechanisms whereby bacteria or other organisms can be resistant. So some examples of this could include having different pumps in the cell wall, where any antibiotic that tries to get into the organism, they just pump it straight back out. Or they might produce enzymes like little chemical scissors that break down some of the things in the antibiotic that's going to come and try to destroy it, essentially. And what we tend to see nowadays is that we've had these colonies of bacteria that have had to survive and adapt to so many different onslaughts of antibiotic that they're multi-drug resistant. They're good at evading more than one different type of antibiotic. And that's particularly concerning because we then start to run out of different types of antibiotics that we can use against them. So where are we now at the moment? This has been a problem really since antibiotics first were introduced, but it's now one of the biggest causes of public health concern that we've got. Obviously, at the moment, all of public health is overshadowed by the current pandemic, but it is worth remembering that we still do have this. And there's a growing number of infections that are becoming much harder to treat. So common infections that we've spent the better part of the last century trying to eradicate, such as HIV, TB, sexually transmitted diseases like gonorrhea and chlamydia, and lots of the different causes of pneumonia like strep pneumoniae, Staphylococcus aureus. They're all showing different types of resistance. So things that were once very easy to treat, and in most cases still are, it's becoming more and more likely that we'll find it much harder. And this has happened to the point where we now have these titled strains of resistance. So Penicillin Resistance, Staphylococcus aureus, extended spectrum beta-lactamase producing species, which produce these enzymes I was talking about that can break down penicillin type antibiotics. And they've given rise to these so-called superbugs. And what this has meant for us in clinical practice is it's more and more likely that we have to recycle old antibiotics. So some of the earlier types of antibiotics that we've since designed better and better types of, we've had to bring them back in, and it could be that they're more expensive or that we don't like the side effect profiles as much. And the reason for this is simply because we don't have, there's too much resistance to the new antibiotics sometimes, that we're now in laboratories when we get samples on swabs and in blood samples, and we grow a bacteria from it and we test it against different antibiotics in the laboratories to see what might be able to kill it off. We're having to use more and more older ones because there's a strong chance it will be one of the older ones and not the newer ones that we prefer that is effective. And something that we do know is that in developing nations where there tends to be a higher burden of infectious diseases anyway, as well as weaker health systems to cope with the problems and get resources out and do surveillance and monitoring, the burden there is felt much higher already. And we expect it will continue to be the case in future as well. So if you just picture for a moment that you are a doctor or a member of a healthcare team back in the 1940s. So in 1943, this was when penicillin first became massively available, and obviously it was taken up really well. It was used very widely. But you're, let's say, a doctor or a nurse on this very dated grayscale looking ward, and a patient's come in with an infection that you normally would just throw penicillin at them for, and you take it for granted that they would just get better. But for the first time ever, they're not improving, and they go on to have some pretty poor outcomes because you're not able to shift that infection. Now, later that year, the number of cases that the scientific community have reported jumps to 37. So that's 37 people who we weren't able to treat with penicillin alone that had previously worked. And this was in 1947, the first documented case of there ever being penicillin resistance in a clinical environment. But it had been documented even earlier than that, when it was still being played around with in laboratories in 1940. So there's a good timeline that I found here on the right, which shows us on the very right when certain antibiotics that we were discovering in the century, some of our favourite popular group ones, were first introduced and taken up massively. And on the left, you've got the first documented cases of different species of bacteria and when the first time of resistance was demonstrated. And as you get further and further through the names there, you'll see it goes from having an R to down here we've got XDR, which is extensively drug-resistant tuberculosis. So what that means is it's gone from the point of it maybe just being resistant to one type of antibiotic, so erythromycin here, for instance, to pretty much anything we can throw at it. And then at the moment, certainly in a lot of developing nations, extensively and multi-drug resistant tuberculoses are a humongous challenge, because TB has already been one of the diseases that absolutely ravished certain parts of the world in the last century, if not earlier. And now we're seeing this type of TB that is only ever responsive to like one or two types of drugs, and those two drugs are monopolized by the pharmaceutical industry. They're very expensive and they're not widely available in the parts of the world that they're affecting, and they're certainly not easy to distribute there. So these things are becoming a real problem, particularly in places that have weak healthcare systems. So with this slide, I wanted just to highlight a few other resistant species that might be of interest or people might be kind of familiar with already. I've not talked too much again about resistant types of virus or fungi that we've got, because again, there's just not too much in the public eye about them. But here we go anyway. So Clostridium difficile, you might have heard of this as being one of the common types of hospital diarrhea that people can get, because what tends to happen is someone will come into hospital, they're treated with antibiotics, and C. difficile, which lives in the gut anyway, might be the only type of bacteria that survives this use of antibiotic, because antibiotics can of course wipe out more than one type of bacteria when we use them anyway. So C. diff will then go from being a really tiny colony that's suppressed by all these other bigger colonies of bacteria in the gut, over proliferate and cause this quite extensive diarrhea that can cause a lot of inflammation and have some potentially very bad outcomes for patients. So we're seeing an increasing number of infections and deaths because of that per year. Another example that we've got is Penicillin Resistance Staph aureus, which I've already mentioned a few slides ago. But Staphylococcus aureus is probably the most common, if not one of the most common bacteria that we've got. It lives very harmoniously on most people's skins and in other places, and it's known, when it gets into the right spot, for causing soft tissue infections, skin infections, joint infections, infections around the heart and respiratory tract infections particularly, and usually should be very simple to treat. But if you've got Penicillin resistant Staph aureus, it means you can't use a drug called vancomycin against it, which we love to use for Staph aureus. It's what we have first line in a lot of the guidelines. But if you've got MRSA, it's about twice as expensive to treat and has about double the mortality attached to it. And you can see that there's again like a high number of very hospitalized cases in each instance. Another one I just wanted to mention, because it had a lot of press a few years ago, got some giggles, but it is still very serious, is multi-drug resistant gonorrhea. So this is something that, although it doesn't necessarily come with a very high death rate, it does come with a high chance of causing lots of bad outcomes from a sexual health perspective in terms of infertility, and in parts of the world where it is particularly bad, where HIV prevalence is quite high as well, it does increase the chances of getting HIV because of the impact it has upon people's immune systems anyway. So now at the moment, in the way the world is, we've got quite desensitized to seeing things about infection rates and death rates. So these numbers might not seem particularly high, but if you were to add up roughly all of the deaths caused per year by resistant bacteria, at the moment it's about 700,000 per year. And in a little bit, I'm going to go into talking about where we project that that's going to go, because obviously at the moment, compared obviously with coronavirus, that really doesn't seem high at all, which is an awful way to have to look at it, but it's set to get much worse, unfortunately. So how did we get here? Like how has this become the way that we are? So I'm going to talk about this first from certainly a perspective of hospitals within the UK. So in the UK, we do a lot of what's called empirical prescribing, which is where if a patient comes in, let's say with a urinary tract infection, for instance, we know from lots of past research and the way that things just tend to go, we know that it's the most likely cause is going to be E. coli, and we know, again, historically from cases and reports that have worked, what E. coli is likely to be susceptible to, and that's two antibiotics called nitrofurantoin and trimethoprim. So we tend to do that and then send a urine sample away, await the laboratory results, and if it turns out that our little E. coli that we have grown is actually resistant to both of these, then we've got to change to something else. But these lab results can take a couple of days to come back because they have to be posted somewhere, the tests have to be run, and it all in all is just quite difficult. So we rely on this empirical prescribing to kickstart people on what is most likely to be the right treatment before things get worse. But this can increase the selection pressure that is applied to not just the E. coli, but any other of the bacteria that are just living in a person's body as well. And we also do a lot of prophylactic prescribing. So this is where we're prescribing, say, for people who are due to go into surgery, people who are going in, they have some kind of immunosuppressive condition anyway. So they might, for instance, have HIV, they might be missing their spleen, and we put them on antibiotics just to reduce the chances of them getting some kind of infection that they're not going to be as capable of fighting off themselves. So these are all types of prescribing that do save lives, but the flip side of them is that they increase that selection pressure. We're also quite guilty of overusing antibiotics for inappropriate causes, and this is echoed world over. So I think many people can report having thought they needed antibiotics for the common cold, for instance, for a sore throat, when really they were probably viral things, and we don't have antivirals that fight those off because we just don't need them. Our immune systems do the job. But we've built these ideas that antibiotics are really powerful things that do work, which is correct in the right case, but we tend to take them for lots of things. And because we don't always need those lab results to come back and prove that we need them, it's quite easy to get hold of them. And there's a Gov UK statistic that I've got in the image here on the right that says we have about 1 in 3 patients in hospital on antibiotics at any one time, and 1 in 3 individuals within the community, 1 in 3 of all of us listening to this will be taking at least one course of antibiotics this year. There's also over availability of them. There's a massive pharmaceutical market for them. Again, like I said, they're very easy to get hold of, and we've become quite dependent on them. They're very written into our guidelines. And this statistic here, even though it's from quite a few years ago now, it shows how in just about a 3-year window or 4-year window even, antibiotic consumption rose by 6.5%, which is a tremendously high figure for just a few years when you consider that antibiotics have now been around for the best part of a century. And these are just a few, there's a lot of graphs that you can find in different parts of the internet that tell you lots of things about how antibiotic resistance is going up, and it's different in different areas because, again, a bit like how populations and demographics of people are different in different places, it's the same for resistance. There might not be as high resistance in Liverpool as there is for one type of bacteria as there is down in London, for instance, and Womborne's, the way that will look will be very different. So if this works, there's a little resource I found here, which if you're interested, feel free to note down the link to. But if someone's able to tell me if this works, if there's somebody listening and hasn't just stayed on my old slides.
It's working.
It's working, fan. Thanks. So what this resource gives you is a map of the world that somebody's very cleverly put together, and you can select here what pathogen you'd like to look at. So I've got it set to E. coli, and you can select which antibiotic you're interested in looking into. So it's set to fluoroquinolones, but I can change it to carbapenems. I can change it to coamoxiclav there, and you can see different parts of the world, and it will tell you, based on some rough surveillance data, what the resistance in reported isolates, so an isolate being a type of that bacteria that's been grown in a laboratory, what that is there. So you can see that on a lot of these, certainly for large parts of Africa and Southeast Asia, there's quite a lack of data. I mean, for certain ones, there is a lack of data altogether as well. It's a growing database. I had it on fluoroquinolones before. But you can see we know roughly what it is, say, for the UK. They reported quite a high number of isolates there, so that's quite good data, maybe not so much there in Russia, but for a lot of Africa, the data is just completely missing. And that's because they don't have, in a lot of countries, there surveillance systems that are quite as robust, quite as capable as we do here. So we have no way of really quantifying what resistance is for a lot of the world very well. And that's one of the big issues with tackling this issue at the moment. So a lot of what I've talked about so far has been very Western centric. And I wanted to throw the spotlight on somewhere that I've unfortunately not been able to go this year with lockdowns, but I've done some remote research with a research team out in Malawi. And I wanted to talk through a bit of what I've learned about that and how the situation is different in low middle income countries, in developing settings, to how it is at home here. So Malawi is a sub-Saharan African country in kind of the lower southeast part of Africa. It's most famous for having Lake Malawi, which runs along most of the country, which is in this picture here that was sent to me all of about 2 days ago by a supervisor of mine who lives out there and is obviously enjoying lockdown there at the moment. But it's one of the most impoverished countries in the world, has a growing population of about 18.93 million, a lot of whom live below it's some of the most impoverished people in the world, really. So their healthcare systems are really bad. There's a very low number of healthcare professionals and healthcare facilities that they're able to get to, and this subsequently has driven a lot of their antibiotic use. And that's what my research was looking into, really, was what is the nature of antibiotic use and people's relationship with antibiotics there, as well as other types of antimicrobial, because they've got a very high malaria presence in Malawi as well. So they use a lot of antimalarials, and there's a lot of resistance to those being seen as well, which is a huge problem there. So I'm going to try and talk you through some of those. So my image hasn't loaded there, but this was just to demonstrate again where Malawi is. And you can see here how huge a body of water Lake Malawi is. Just a fun fact about it for you. So what's happening elsewhere in the world? So if anyone is interested in reading up about what the study is that I've done work for, it's called the Drivers of Resistance in Uganda and Malawi study. And it is just exploring what those drivers of both infectious diseases and antimicrobial resistance is in sub-Saharan African settings. So the picture that I've got over here on the left is to represent households who have antimicrobials essentially in their cupboards, who they've stockpiled them, which at first glance might seem like quite selfish, reckless behaviour. That's not something that we're told to do by our doctors here. We're told to take our courses as we need to, when we should know that we're supposed to do that. But in Malawi, it's kind of a problem that arises because they're very hard to get hold of, and there's a lot of infectious disease going around. So when when households get ill, whoever the head or the primary caregiver of the household is, will do their best to try and source antimicrobials from somewhere, because they'll have that knowledge from the one time that they were able to get hold of them, that they work really effectively, and that they were able to help somebody out. So they might have incomplete packets of antimicrobials that they've taken half of once and saved for future use as kind of like an insurance for the future, if you will. They might source them from their neighbours, or they might be able to buy them very easily over the counter, which is what this picture here symbolises. So as in even certain parts of Europe, it's very easy in Malawi if you go into the private facilities, so not the public healthcare facilities, which are very stretched, very hard to get hold of. You have to walk a long way to get to them, and very often they're closed or not staffing, like the staffing isn't fully equipped to help you. But in the private sector, if you can afford to do so, you can probably go and buy antibiotics over the counter quite easily without a prescription. And this was helping people to have them in their homes, self-medicate with them out of necessity, but perhaps use them incorrectly or use them for purposes that they didn't need to. And this picture in the middle here is something that we often neglect to think about with antibiotic use. It certainly isn't my area of expertise as a medic, as opposed to being a vet or an animal expert, but almost in the same degree as how much we use antibiotics in healthcare, we use antibiotics extensively in the agriculture and livestock industry. So I think it's something like, I've got it down here, 63,000 to 240,000 tons a year of antibiotics are used in the livestock industry. So this is used, for instance, it's added to feed. It might be used in crops or as like a growth supplement to help cattle like these, or poultry, pigs, whatever it is, grow bigger and stronger and survive, again, the range of infectious diseases that are just as likely to wipe them out as the people in these parts of the world, because a lot of people are really reliant on having to farm their own crops or livestock as well, just to be able to eat and to make some money. There's not a lot of other ways of making money for lots of people in rural parts of Malawi. So if you aren't able to kind of take your chicks into adulthood and survive, then that's a lot of lost income for you. It's lost food and a lot of lost time as well. So what we found in our study was that a lot of the bags of feed that we were kind of being used in households would have all different kinds of antibiotic in them when tested, but there was nothing about it on the labels. And it is something that, at least in Europe, we do very heavily regulate, but here it was very much unregulated, very widely available, so hard to say again what these animals were being exposed to. And to explain why, certainly from the animal perspective, this is a bit of a risk for us, you've got to understand that just because it's in the animal doesn't mean, say if this animal was exposed to antibiotic and this means that the pathogens within the animal become resistant themselves, it doesn't end there. We find that animals obviously produce mess. This can cause what we call environmental exposure or overspill that can come into contact with humans, and we then ingest this and it colonizes us. Or they might even be in improperly cooked foods still and infect us that way. We also think that there's a lot of, certainly in our pesticides and things that we use, it can get into more places than we would like it to, even if it's just on our crops or in our animals, it can get further away than we want it to. So local wildlife can pick up on it, for example, and then it gets into the human population. And then this image here just explains those self-medicating behaviours a little bit better, but I've kind of already touched on it really, whereby you have these resistant strains which add strain to an already high burden of infectious diseases. This causes people to need to medicate over the counter, which again drives further emergence of resistant strains. So it's a bit of a caught between a rock and a hard place kind of situation, really. So to look at how AMR is going to affect us in future, we've already talked quite a lot about how it's affecting us at the moment. You need to cast your minds forward, to where we might be in about 30 years' time. So we've got quite a lot of predictions, again, which are based on probably under predictions, because we don't have very accurate readings on what's going on in certainly low-income developing parts of the world with antimicrobial resistance. And currently there's already around 700,000 deaths a year from it, as I've already mentioned, but we do predict that by 2050 we'll have about 10 million deaths per year. It's going to cause a shortfall in output of about 100 trillion a year, and just a whole host of bad problems, really. And you can see in these pictures that I've included here, so to understand this diagram a little bit, it works outwards in terms of years. So this is where we are now on this inner circle, and this is where we expect that we're going to be in 2050. So you can see in terms of proportion, it's expected that it will overtake cancer as our leading cause of death by 2050. So if it's not that serious a problem at the moment, you can consider how, if we keep going the way that we're going, it's going to become really bad. And again, this map here was designed to predict where the burden of these deaths is going to be. And a bit like we could see on those maps that we were looking at before, you can see that the predicted burden of deaths certainly is set to be within the more developing parts of the world, or at least the African and Asian continents. So that's been quite a lot of negative talk so far, but I want to put a bit more of a positive spin on this, because there are things that we can do to try and curb this. And there's definitely things that we are trying to do to curb this already. But some of the ideas that might seem logical just really don't, unfortunately, make any sense at all. So what things can we do? Could we stop using them altogether? Unfortunately not. As I've already mentioned, we really rely on things like empirical and prophylactic prescribing because it saves lives. If we were to stop using antibiotics altogether, people would be dying from infections that were very easily preventable, because a lot of these bacterial infections that, you know, one person might be able to fight off, somebody might not have the reserve to, and it could be an antibiotic that makes the difference in them walking out of the hospital, or unfortunately not doing so. Can we wait to always have lab results before we prescribe antibiotics so that we make sure we're giving the right one, not using that unnecessary selection pressure? We can't really do that either, because at the moment, like I was saying before, lab results can usually take around 24 to 48 hours to come back. If you want to send a sample away to look for even more specific mechanisms of resistance to know exactly how it's functioning, that can take, you know, a week, if not longer, and even longer when you're looking at viruses and different rarer types of microbe in particular, because we just don't have the infrastructure for it at the moment, if we do, even if we have the technology. Why don't we just invent new drugs, considering we were able to do so many in what we term the antibiotic golden age? I'll get onto that in a moment. The two things that we really love and are really pushing at the moment are these two concepts of antimicrobial stewardship and individualized therapy. So we're just going to go into those in a little bit more detail now. So the development of new antimicrobials, as I said, it's not really as easy as we'd think. So if you have a little look here on the map I've included there, and just a headline down there that the World Health Organization released. So it is a very globally known thing that we have a lack of antibiotics emerging. And this is because the bulk of effective groups of drug was really discovered in the past century. And it's been at least 30 years since we did discover a new class of antibiotic, if you will. So all these different groups here, there are more groups than this. But within penicillins, there are different types of penicillin, but they all have the same mechanism of action. So if you have a bacteria that's resistant to one type of penicillin, it's likely to be resistant to another, and it's also likely to be resistant to ones that have very similar actions and properties to it as well. So we're kind of dry of ideas, really. And even if we were to come up with something, as we've seen a few slides back, microbes are very quick to mutate, they're very quick to get clever, so we'd have to constantly be coming up with new solutions. One of the big problems at the moment is that research is dependent on time and money, and also interest. So one of the reasons at the moment that we have so much in rapid research coming out about coronavirus is it's because it's the big thing that we're all very worried about. So things have moved much faster because they've had the interest in the funding, and when the funding isn't there, people can't make grants, they can't employ people to do the research, they can't just rack up the general interest. And it also takes pharmaceutical companies to take an interest and believe that this will be something that turns profit. And at the moment, antibiotics just aren't a profitable industry, so there's not much investment in it. Now, the WHO, or the World Health Organization, has got around 50 pipeline antibiotics listed as ones that are being explored or are in development or in drug trials. But it's only expected that between about 2 and 5 of those will be available in the next decade. And even then, we can't say whether they'll be effective or whether they'll just sort of slip through the net, unfortunately. So antimicrobial stewardship. So if you're someone who works in healthcare, this might be something that you are quite familiar with already. It's certainly one of the biggest pushes that we have within the hospital and other environments clinically. So it's an umbrella term for a lot of the strategies that we've got to raise awareness about antimicrobial resistance and principles to hold everyone in the healthcare environment responsible and aim to slow it down, really. So it's what's widely done in hospitals already, but some of the things that this might include could be providing education about this. So I suppose in a degree, what I'm doing here today is antimicrobial stewardship. I'm teaching you all about it. But also kind of educating clinicians on how they can be better, educating the people that are the gatekeepers to antimicrobials on what they can do to be guardians of them a little bit more. It involves using and prescribing them only where we really think there is a need to. It involves making sure that we try to prevent more infections than we cure, because that is always ultimately better than having to cure things. It means having these different policies and systems in place that encourage sustainable use. And I'm going to try and touch on that in a moment as well, explain what this needs. And having policies that are tailored to local needs. So as I explained before, resistance patterns can be unique in different areas, and that's why the guidelines that I would have working in the Royal Liverpool Trust will be different to the ones, say, down in London, for example, because the resistance there is different. So different first-line drugs are more likely to work. And you have to tailor it to local policies and always make sure that you're following the most up-to-date evidence and things like that. And that means that we have to have good surveillance and good reporting in place to be able to do so. So what this might look like in practice, again, this was taken from the government website from a report that came out a few years ago. So certain things that the government, or certainly Public Health England, which is currently going a rebrand, but we'll still refer to it as Public Health England, something that they try to do is come up with certain incentives for clinical commissioning groups, CCGs we call them, that might look out for different GP practices or different areas of hospitals, is to set targets for them to reduce their antibiotic prescribing. So this can sometimes put pressure on clinicians to cut out the amount of unnecessary prescribing that they're doing, because then there'll be positive incentives for that trust. And what that tends to translate as is that over the past few years in different areas, we have seen a drop, or certainly a stagnation, in the number of resistant species that we're seeing. So it is being seen to work. And one of the things that we use for this is the Public Health England national targets. So there's a website, if this works again now, that you can look on here. So this is called Public Health England Fingertips. I'm assuming you can all see this if you were able to see the last map.
We can all see it. You're doing great.
Fab. So this is another kind of interactive thing, and I've set this to Royal Liverpool and Broad Green, which is my trust. But you can set it to pretty much anyone in the country. You can set it to county specific. You can set it to, I think, care commissioning group or GP specific if you really wanted to. And you can essentially see how your hospital, so this really is mine there, you can see how it's comparing to other parts of the country, whether it's above target for antibiotic prescriptions, whether it's above target in terms of having vaccinated frontline workers, whether it's on target for various different things. And you can also have a look at trends here. So I think this worked before. With a few other things. It's interesting to have a look at anyway. There's different like targets of things you can set it for. So here it talks about kind of bacteremia. So this is something that I've done some research into while I've been in the trust. E. coli bacteremia is something that are really concerning. It's an E. coli blood infection, and we're seeing more and more resistance to it. So in a bid to both curb the resistance, we're making sure that we do everything we can to keep the bacteremia levels down. So preventing resistance is both about keeping your infection rates down, as well as about keeping your antibiotic use to just that which you need that's sustainable to minimize the resistance that you're seeing. But different types of surveillance essentially look like that, and we've got very good surveillance systems in place, was the point that I'm trying to make there with that. So individualized therapy. So this is an area that is kind of new and upcoming. I'll be honest, it's not one that I know too much about, because it's one that it's still very specialist. It's quite lab-based, but individualized therapy is something that applies across all types of drug. But what it means in the context of antibiotic or antimicrobial prescribing is that all antimicrobials should be perfectly tailored to the individual and the exact infection that they've got, as opposed to being based upon guidelines and based upon a few predictions in the laboratory. So what this could involve could be doing genomic analysis of a microbe. So in the same way that we're currently able to do analysis of different types of coronavirus and predict which mutations are going to break out based on the potential mutations that we think they have the capabilities to do, it will be to make this technology more accessible so that we're able to do it with all sampled bacteria as well, because at the minute it's something that's very difficult to do, it's very expensive, and we just need to hone those processes, make them faster and more accessible. And if we do this, we'd reduce that need for empirical prescribing. It might also mean being able to link antibiotics up directly to pathogens in the lab, because at the minute what we tend to do is come up with a big list of whether something is susceptible or resistant, And from there, a microbiologist usually has to choose, or a clinician has to choose what they want to use based upon often just random decision, to be honest, or again, what the guidelines and what a peer is recommended. And what one of the big pushes is for at the moment, what we think we're capable of is having artificial intelligence. So those same kind of things that generate your adverts in social media and tailor it to you, we think that they could be great at looking at both what the bacteria is that is infecting somebody, somebody's immune status, lots of different things, and kind of go ding, 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 this is the antibiotic that we have to use. This will be most effective for this course at this strength, because at the moment, the strengths and the courses that we use aren't really altered vastly amongst groups of people unless you're dividing people up into children, adults. But it would be good to say what might work for me could be a 5-day course, what works for somebody else could be a 3-day course of a drug at a slightly higher dose. And we just don't have the technology in place to be able to do that right now, but that would be the ideal scenario. And then we would never have to be over or underusing an antibiotic unnecessarily. So obviously all of these approaches do involve using antibiotics in one way or another. So the best thing that we really all can do is to hope for prevention over a cure. So if there's anything that we've been taught by all this hands, face, space stuff, social distancing, is that it's better to stay out of harm's way than it is to tempt harm in the first place. And that's one of the best things that we can do to save lives. And this isn't just the case with coronavirus. This is the case with any kind of other virus or infection. Now, obviously, a lot of infections aren't all spread the same way as coronavirus. So it's all about kind of heeding safe measures for lots of things in life. But some of the main things you can obviously do to prevent infections is keep a clean space, be hygienic, wash your hands. There's a lot of good things that we already have lots of good data in terms of face masks, not just for coronavirus, but for instance, our flu rates this year have been very low. Our common cold reporting has been very low as well. So it has been effective for lots of things. A concept that is quite interesting, without harping on it too much, telling you that you need to wash your hands, is something called WASH. So that's water, sanitation and hygiene. And it's a big concept, particularly in humanitarian crises, whereby, say, if there's been an earthquake somewhere or something and you get humanitarian organizations coming in to help make refugee settlements, you then very quickly tend to see big outbreaks of disease because there's a lot of unsettlement. People don't have access to basic hygiene facilities. So you'll get experts who come in who are, their only job really is to come in and make sure that there is access to chlorinated water so that people aren't at risk of diseases like cholera. They've got safe places to use the toilet and to shower and things like that. So then again, they're not exposed to fecal contaminants that can get them ill, because that's one of the biggest things that can lead to deaths in refugee camps particularly. So this is something that we don't just practice in our part of the world, we practice it the world over, really. So a few take-home messages. So hopefully this all hasn't been a bit too overwhelming for you. Not too negative. There is hope in the world. There are things that we can still do, but you might be sat there thinking, well, a lot of what I'm talking about again is very clinician, it's very healthcare centric. So what can you, the individual, do? If you do ever have a thought in your mind, you know, you've got a bit of a sore throat or something like that, always think, do I really need those antibiotics? But certainly, as we've been told with hospitals at the moment, if you need to go, still go. If you need antibiotics, do use them, because they do save lives. And at the end of the day, what we're trying to achieve is some kind of balance whereby we still use them, but we're able to use them more sustainably and not be as worried about resistance in the future. Remember that some of those hand, space, face and other prevention methods still go miles. So having to walk into shops and use hand sanitizer just on the way in and way out, there's definitely ways, I certainly believe, that society's changed recently that is for the better, and there's things we can incorporate into our daily lives that will help ourselves out in the long term, really. As I said before, always ask yourself if you really do need antibiotics instead of assuming that they're the answer, because this is something that society over, we've all been in the habit of doing. We need to probably move away a little bit from if we're to keep being able to use them at all. Always keep your homes clean. Make sure you separate and prepare food well, because we still see very high amounts of infection from people eating things like undercooked meats, food that they've not prepared well. And get vaccinated. Vaccines, as we know, are probably the main other medical preventative measure that we've got for infectious diseases, there's only so much we can do with things that are designed to supplement the immune system, such as steroids and other biologic drugs. Vaccines are the first line of thing we've got for breaking transmission. So that's in the medical world, is really touted as the main contender for antibiotics as well. So yeah, thank you for listening. Hopefully I've not harped on it you too much and made you interested. Free to take any questions. I think I've probably wrapped it up at quite a good time, I think.
Thank you so much, Vicky. Wow, that's so interesting. What a journey that is to realise such, a scale of a problem and then look at some of the solutions as well down the line. It sounds like it's going to be an interesting few years ahead for the problem. Crazy. Okay, so the current time is 2022, just ticked over. I suggest what we do is have a quick 2 or 3 minute break, pop out, refill your cups of tea or your beer glasses, and then we'll come back for a short Q&A section. I'm fully aware, those of you that are tuning in on YouTube, or 14 of you, thank you so much for tuning in today, that the YouTube chat section is down. So unfortunately, no questions and answers from YouTube today. However, don't go away. In a couple of minutes time, I'm sure there's going to be some interesting discussion. So yeah, 2 minute break and we'll be right back with you.
Okay, thank you.
Should probably create a back in 2 minute screen, shouldn't I?
Might be a good idea.
And all of us just sit on camera.
With some kind of like the Benny Hill theme tune music.
Yeah.
Very good.
Thank you. Okie dokie, the time is now 2025. Still with us, Vicky?
I'm here.
Still with us, lovely jubbly. All right then, so time for some questions and answers. Either I invite anyone to type their questions in the chat box or come off microphone, turn on your cameras, and we'll have a conversation person to person. So I'll start the questions and answers off. I was just wondering, in your experience in the clinical world up at Liverpool, what is the situation for antibiotic resistance in the Liverpool hospitals, and what are the people up there doing in the short term to solve it?
Yeah, so a lot of what I was talking about from certainly the England-centric side of the talk was based on experience that I've had at the Liverpool Royal. I did a fairly biggish project there back in September, looking into E. coli. So that's one of the pathogens I was talking about that causes urinary tract infections. It's found in our gut, and it's known to cause really bad bacteremias, which is where you get bacteria in the blood. staff there were really concerned that resistance rates were rising, so they wanted me to kind of go back through all these records and have a look at how things were changing. And certainly what we were seeing was across all these different markers, it was going up to some, it was going down to others, and it was interesting to see how it was going down to the ones where there'd been national targets set to reduce that kind of antibiotics. So it's a changing thing, and it can be influenced very quickly, but certainly within Liverpool, because the hospital I work at is it's a centre for infectious diseases, it gets a lot of the weird and wonderful things. So we do see a lot of the we get HIV patients coming through. We get, at the moment, I'll be honest, a lot of it is coronavirus patients because that's the way hospitals are, but we do get a lot of the weird and wonderful things coming through. So it's not uncommon to see, if not read, records of people that are very resistant. Certainly you'd expect there to be more there in a city population where things spread more easily anyway. There's more human to human interaction than, say, in a really rural part of the world.
Interesting. Philippa asks, do you think that patients are becoming more sensible and not asking for antibiotics when they have a cold or viral infection?
So I've not done any GP in a couple of years now, and definitely when I was last there, a lot of what you get is people will come in, they because this would have been back in my 4th year, so I was able to have consultations. I'm not able to prescribe at the moment, but I can say what I'd like to prescribe and somebody can do it for me. I don't have my license to prescribe just yet, but a lot of people would be coming in with a cough or something that they were struggling to shift, and as the clinician, without the laboratory side of it there, you've kind of got to make that decision based on what you can see and what you can hear in front of you about whether it's more likely to be viral or bacterial. So obviously an antibiotic, because I was saying they work against bacteria, it's not going to work against something viral. They can stick around for a long time and you've just got to wait for it to shift on its own, really. But a lot of people just kind of do jump. We make this link in our heads that bad infection means I need antibiotics, means I've got to go and ask for that. And if you've got a great relationship with your GP, they're very likely to listen to you, and the patient is very often the person who's right. So without better proof, they're probably not going to question it. But there's a lot of education now, a lot of pressure from the top, certainly, that we shouldn't be caving in quite as easily to people demanding antibiotics. And by demanding, I don't mean that they kind of come at you with a pitchfork, and if you don't give me my antibiotics, we're not going to let you go. But we're just conditioned from them having worked for so many decades that that's what works and that's what we take. But there's better education, but yeah, without having seen it from the GP side for a while, I don't know. But certainly within hospitals, we have a lot of guidelines that just tell us you need to use antibiotics. So to give an example, if you've got someone that you suspect has sepsis, which is where you've got an infection that you've got a dysregulated response to and some kind of sign of organ damage, it's bad, it's got a very high mortality. Guidelines tell us that within 4 hours we should be on whatever the hospital recommends is the first line antibiotic. So without even having blood culture results back, you're just going to give it. And we can be very trigger happy with just giving antibiotics. And sometimes what you come across in medical notes is one person will have started one thing and then someone stops it a day later because they disagree, and then you've had somebody pointlessly be on antibiotics for a day, and it can be very messy because there's a lot of chefs spoiling the broth, if you will. So it's a lot of education and standardization needs to definitely be put in. And I can say that from the perspective of having stood back and gone, everyone's got very different ideas about what we should be doing. So hopefully that didn't overcomplicate the answer for you.
Victoria, with older people, older than me, I think that generation expected antibiotics. I think hopefully now with more education, we realise the situation that, hopefully they went, doctor hasn't given me anything,
That's the thing. I think a lot of people think that it's kind of an offence when they come away without them. It's not the case. It's just that, if we say you have something viral, we can't necessarily give you anything apart from a pat on the back for it. And we can't even give you a pat on the back at the moment. We have to give it you through a computer screen or a phone call. So it's breaking down that idea that just because you've not received medication, it doesn't mean you've not received care. Because very often people see having received a prescription when they leave the GP as that something has been done right. And I think a lot of, like you're saying, your generation particularly, I imagine there wouldn't have been many reported cases of resistance. It wasn't as in the public eye in the same way that things like climate change weren't. It's something that we know a lot more about now, and it can be harder to shift your ideas if that's what you've always been used to, I think. Yeah.
No, thank you.
Victoria, is there any evidence that cattle and that are getting more resistant to the antibiotics they receive? Because they're routinely injected, aren't they? We imbibe it from them if we meat eaters anyway.
So there's definitely, so the research that I've done that was relating to antibiotic use within animals, it wasn't so much looking quantitatively at, say, this percentage of bacteria within cattle are resistant. It's something that's known to happen. That's not something that I personally have research experience in, but the reasons behind my research were because we know that that happens anyway. So we were looking into what the drivers of that were, and that was that we learned, okay, they're being given all these foods that are full of antibiotics and we don't know what's in them, it's unregulated and things like that. So definitely it happens. We know that just as in the same way that you could take antibiotics and a resistant strain could develop in your body, a cow is the same, it's the same vessel, it's the same host that can produce excrement. The excrement gets on crops, that's grown, it's then on things we eat. I'm oversimplifying it, but it's there, but I would have to be more on the numbers side of the research to give you a figure, but I'm sure it will be available somewhere. But yeah, trickier one because we don't take as many samples from animals as we do from humans. So we're much better at quantifying it with humans. I think someone's asked about...
Just be careful where you're sourcing your hamburgers from.
Yeah.
Yeah, Linda asks, have you come across the use of bacteriophages?
Oh, I'm familiar-ish with them, but I can't say I have. But that's one for me to go and look up and do my homework on.
They've been around for a very long time. Am I on mute? Yeah.
We can hear you.
As soon as I talk, he barks. Sorry. They've been around for a very long time. I just wondered if the development of antibiotics has sort of stopped them looking at an alternative. So perhaps they'll start looking at them again.
Yeah, I think essentially it's one of those where like it's there, but certainly, so as someone who is about to enter into the medical profession, we look for research opportunities alongside all the clinical things, and there's been a lot of I'm currently eyeing up the prospect of going into a lab that has something to do with antimicrobial resistance, but there's not much mention of bacteriophages. So I know it's there, but you're right, it's not very high priority. And the other sad fact is that all the things that were high priority this time a year ago have just been completely kicked out with COVID research. So there's plenty of that to be going around. I work on a bit of it myself already. I'll probably end up working on a lot more of it in the next few years. And then all of this gets sidelined because that's just where the money gets pulled. So I think if there was an interest, you're right, it wasn't quite as big. But I'm not 100% sure why, like what the results of it or the problems with it were. I think we tend to in medicine have a habit of kind of sticking to what we know, and we do sort of know where we stand with antibiotics, but even if we don't have newer ones, it's sometimes harder and scarier to bring these completely new classes of treatment out and get them popular, because there's also there's a communication side to it as well, whereby, like we were talking about with people having to be taught that antibiotics aren't the be all and end all, if people aren't familiar with bacteriophages, it's not where they're going to jump, it's not where the investors are going to go, yep, that sounds good, we know it works, we'll put money into it. So I think it's fallen prey to that kind of problem, but won't claim to be the expert on it.
As I was sitting listening to your talk, I was thinking about how I think over the history, there's a lot of things, maybe antibiotics, but generally treatments as well, have come from the natural world. So thinking digitoxin from foxgloves, for example. So there's probably a lot of answers in, a little square of rainforest out in Southeast Asia that tomorrow is going to be a farm.
Yeah. Well, this is the thing I noted down, obviously, about the first noted cases of resistance, but we don't actually know if that was. It's very hotly debated whether there was some kind of, certainly we had antiseptic type things in more indigenous populations that they've been using for decades, not longer than decades, centuries, that we've incorporated into modern medicine. We don't know if there's similar things in other parts of the world that we've just been missing a plant off a tree or something like that, but we will see if it arises in future. The answer could be in nature, but we need to be careful with nature if we're going to find it.
Were you going to add something to that, Philippa?
Were
you going to add something to that, Philippa?
No, I just think back to when I used to teach the A-level biology. And I think it was, I don't know if Linda can remember, Madagascan periwinkle. It was a plant that they came across, and they found that it contained the most amazing chemical that would have been fantastic in medicine. And when they went back, it had all gone, been destroyed. The whole area just disappeared.
Yeah.
And there are so many, as you say, so many chemicals in nature, plants, soil, everything that, that have developed over billions of years. We come along and ruin it all. Sorry.
Mm-hmm. We already have a lot of big links in the infectious diseases world with climate change anyway, because it's those changing environments that they increase kind of like the interface between animals and people, and zoonoses, to those kind of bacteria that, or viruses even, that will jump from animal to humans. There's more chance of that happening because we're migrating, we're cutting down, Ben, you'll know more about this than me, but cutting down the places where animals live, and interacting more and more with different things, trying to harvest the natural world more and more, and exposing ourselves more to things. So I think there's something, again, I'd written it down out of interest, how many infectious diseases we think we have emerging a year.
Too many.
Many was the answer. I can't quite find where I've written it down, but we just predict it's going to also go higher and higher the more that we start to mess with things, basically.
Yeah.
Yeah.
Any last questions for Victoria before we bring this evening to a close? No, okie dokie then. I invite everyone to just say thank you once again so much for a really fascinating evening. Thank you so much for coming along, Vicky. That was absolutely fantastic.
Thank you.
Okay, so next up, we're going to be a quarter of the way through the year. So next month it is the AGM. So we're looking at Thursday, the 18th of March. For those of you that are members, we'll be starting at a slightly earlier time, 7 p.m. Currently, all of the council positions that are currently available or are currently occupied. Those of us that are occupying them will more than happy to stand for them again. However, if you're thinking to yourself, yes, I'd like to go at that, then please just get in touch with what you'd like to do, and we'd be happy to take a look at it. But otherwise, tune into the Zoom call at 7 p.m. But after that, at 7:30, I believe we have our own Philippa on, do we not? Who's going to be talking to us about the various stories from Madeira. That's right.
It's not difficult at all. There's no scientific information. It's just colourful and escapism.
Yeah.
If it takes us to another part of the world for a bit of lockdown, then that's what we need.
Yeah, just for a change.
Everything from geography to cake, so I'm told.
The cake will have to wait until we can.
Cake will have to wait.
I'm afraid.
So yep.
Yes, thank you very much, Victoria. Brilliant.
Thank you for having me.
Thank you.
Yeah. Thank you so much again, Victoria.
Thank you, Victoria.
And thank you everyone for tuning in on Zoom and YouTube. And we shall see you next month.
Bye, John.
Yeah.
Have a good one, everyone.
Bye,
Take
all.
care now.
Bye.
Stay safe.